Good afternoon or good morning, everyone, depending on where you're calling in from. Thank you so much for joining us today. My name is Annie Osborne, and I'm the Interim Director of Strategic Partnerships with the National League of Cities. And we are so thrilled to be partnering with Pallet on this webinar, Housing as Healthcare. NLC has worked with Pallet for the last several years, and they've been a really key partner to us as the National League of Cities and to cities and communities across the country, supporting them with both housing and homelessness solutions, but also with related issues such as reentry, health, housing supply, workforce, etc. So we have really valued our partnership with Pallet and are very excited to be bringing you this webinar in partnership with the fantastic Pallet team. So today we are going to be talking about, again, housing as healthcare and how to support our most vulnerable community members by integrating housing and healthcare. We all know that these issues are interrelated, and so our hope is that you'll walk away from this conversation today with a deeper understanding of those many connections between these two issues, as well as some strategies for how you as city leaders, as community leaders, can better integrate your work on health and housing to better serve our most vulnerable community members. We're thrilled to have a fantastic panel, which you'll hear more about shortly, one of which includes one of NLC's members of the board of directors, Dr. Aditi Bustles, who's a councilwoman from Columbia, South Carolina. But for that, I'm going to turn it over to Amy King, who is the founder and CEO of Pallet Shelter and who has been a phenomenal partner to us throughout the years. And she will moderate the panel and introduce the rest of the webinar. So, Amy, I'll turn it over to you.
Conversation around the integration and cross integration of housing and healthcare and the importance of panelists, which I'm super excited to introduce you to in a little bit. And then I'm going to share a little more about some of our sites where we have some integration of healthcare. So for those of you that aren't familiar with Pallet, we are a social benefit corporation working to end. They come with wraparound services, support and care, and integration within the community to support the residents who live there. But we also have a secondary mission. We are a workforce development organization. So the vast majority of our staff that work at Pallet are folks with lived experience in homelessness, addiction recovery, and interaction with the justice system. And they heavily inform our product design, our model design, the way we interact with our customers and our partners across the country. And they're a critical, vital part of our success here at Pallet. One thing that we've learned from them and we really rely on heavily is what we call our reintegration ecosystem. So the concept that a person is a whole person and they need a lot of different things in order to successfully reintegrate after a trauma experience or an isolating experience such as homelessness. So that includes everything from workforce opportunities to, financial assistance to all kinds of things. And so we want to work really closely with cities to understand what services are available in those cities, what needs to be supplemented and supported so that people can be rehabilitated and we can ultimately end homelessness in our lifetime, which is our goal. So for those that aren't familiar with us, we do have over 120 sites, Pallet sites across the country that we have developed in partnership with 85 cities in 21 states. So we do have quite a bit of experience working with a diverse array of cities and opportunities. But I'm going to share two specific sites with you today, which we have panel members from to speak more about. One of them is our site in Columbia, South Carolina. This site is unique in the sense that this entire site, from the time they contacted us until residents moved in, took 72 days. That's it. From the time they reached out to us to the day that economically unhoused individuals in their community, and they used ARPA funds and a variety of other resources to prop up this site and get it up and running quickly. So we'll talk more about that in a little bit. One important note about this site that I think is really helpful is 3 people moved to permanent housing within the first 2 months of opening, which is great. And they've moved a number of people on since then. And the site was at full capacity within 3 months. The next site, which we're going to spend a little more time focused on this one, is our site in Boston. This site is especially exciting to me as a person with a background in healthcare. We partnered with a group that you're going to hear from, Lauren Easton, who's one of the VPs of this group, to provide healthcare services, specifically integrated healthcare services on this site for folks that are struggling with addiction issues and substance misuse. And this was state funded. So Lauren's going to give more detail about this site, but a very interesting, awesome site that we highly recommend and think cities can really benefit from in serving their residents that are struggling with substance use. So with that, I'm going to go ahead and hand it over to Lauren. She's going to share a little more about what Commonwealth Care Alliance does and how the site works. So take it away, Lauren.
Thank you so much, Amy and Annie, for having me today. I am thrilled to be here. I've been in healthcare for 25 years, and having the executive oversight and development of our Pallet community, which I'll refer to as our cottage community, has really been a highlight of my career. As Amy said, I am the VP of Integrated Program Development and Clinical Innovation, and we really see our cottage community, our Pallet community, as an innovation to really start having solutions to end homelessness. I am just going to briefly give an overview of Commonwealth Care Alliance and how we were involved or introduced to the Pallet community and our cottage community. But CCA is actually a payer and a provider. Our foundation started in Boston. So as a payer and provider in Boston, we have about 50,000 members across the state of Massachusetts. We've recently moved into California, Michigan, and Rhode Island. But based on our history of serving the most vulnerable population in the state, individuals that have complex medical, psychosocial issues, psychiatric, and substance use issues, we have been consistently known as an organization that is able to serve, engage, and offer comprehensive services for, again, the most vulnerable individuals. About 10% of our population, the members that are enrolled with Commonwealth Care Alliance, are homeless or marginally housed. Next slide, please, Amy. Just again, briefly, a little bit about our uncommon care and our uncommon model. We really focus on providing healthcare services, integrated services, comprehensive behavioral health services in the community, finding people where they're at, whether that's in a shelter, under a bridge, at a Dunkin' Donuts. We really appreciate and understand meeting people where they're at, wherever they are, in terms of their mental health, their medical issues, their substance use issues, developing that relationship, engaging people, and respecting where they are in their journey of recovery. We have a seamless integration of care coordination, care delivery, and care partnership for all of our members. But based on our long history of providing comprehensive care to the most vulnerable populations across the state of Massachusetts, the Executive Office of Health and Human Services approached us to think about a solution for a major crisis that was going on in Boston. Next slide. Again, this is just a slide about our comprehensive range of care delivery services. I will not go through all of this, but as you can see, we do multiple things within our care model. So short-term residential, urgent responses through hospital to home teams. We have primary care services, we have palliative care services, engagement services to, again, provide comprehensive services to individuals that have really had a lot of barriers and difficulty accessing care. And whether that is because of their disability, the distrust of the system, the stigma that's placed on them, they're often, as we know, utilizing the ED for their care, if they're even getting care. Next slide. So as I said, the Executive Office of Health and Human Services in Massachusetts approached Commonwealth Care Alliance after their conversations with Pallet and said, can we be one of the solutions for this major crisis in Boston, what we refer to as mass and CAS? This is an area of Boston where Actually, there was over about 300 people living in tents, and average age was about 40. 95% of these folks did want access to low threshold housing. 49% did not have a healthcare provider. And as you can imagine, many of them were addicted to cocaine and crack and opiates. There was over 5 overdoses per day. This was back in October of 2021. Over the past year and a half, although we have provided this solution with the cottage community, this crisis continues to grow, and the violence is getting worse, the overdoses are increasing, and the city is continuing to look for further solutions outside of what we have already provided. Next slide, please. So as I said, the city and the state were looking for solutions. So we are one of 5 solutions that were responding to this crisis in mass and CAS. So CCA's cottage community was built on the Shattuck campus, and it is unique to the other solutions because we are the only non-congregate solution across the state of Massachusetts. We were able to, like Amy was talking about, the community in Columbia. I was reached out to by the state in October, and our first resident was admitted December 29th of 2021. And we were full within 2 months as well. Next slide, please. A little bit more about our cottage community. We have a 22-bed low threshold temporary housing. Again, as a result from the mass and CAS crisis. What's unique about our program, and again, going back to CCA's history, is what I wanted to develop was a comprehensive healthcare coordinated services for the members that were coming to our community. So we are offering 24/7 nursing. We partner with primary care. We have recovery coaches on site. We have access to psychiatry. And all of these components have been key to the success of our program. Our average length of stay right now is about 3.6 months. And during that time, we have the ability to start to develop relationships with the guests that come in. We've been able to start about, if they're willing and wanting to, we've been able to start 70% of our folks on MAT. And that really starts with that relationship that they're building with the staff on site. As they build that staff, they're more willing to start engaging in treatment, start engaging in their discussions with recovery coaches. We have had a total of 96 total residents in the 18 months that we've been running. And I think this is incredibly significant that we have been able to actually permanently house 74 residents. We had initially considered that our average length of stay would be about 6 months. But with a few outliers, we have remained at about 3.6 months. The other significant point is that all of our residents have remained in permanent housing. Everybody that has been housed has remained there. Not only do we have a comprehensive model on site, but we also feel the incredible importance of continuing those services when folks move into permanent housing. So they have access to all of those services post move into permanent housing. Next slide, please. Again, an overview. I did mention this, a strong model of services and how we manage it. We have initial contact with folks on the streets at Mass and CAS. Some of the work is done by a street team where they're actually ensuring that people have some type of ID, they have some type of documentation, and that is really, again, the key to our short length of stay and placing, is that people are document ready. Transportation is scheduled to us. They're placed at our cottages. We offer transportation to doctor's visits, court. Another big component of our model is recovery coaches supporting people going through various warrants that they may have. Again, another key component to being able to get people housed is to clear up those warrants. We have a comprehensive on-site intake through our nurse. As I mentioned, we have behavioral health coordinators, we have recovery coaches, we have housing specialists that are on-site and off-site, but they're really also working behind the scenes to identify apartments and identifying and working with landlords to ensure landlords are prepared for us to move folks in. We offer 3 meals daily, 24/7 security. We have internet and phone lines. We have cleaning on a daily basis and decontamination and waste removal. In addition, as people exit, as I said, we ensure that they have a warm handoff to the community. We ensure that people are having that continuity of services and really key to their success. Next slide, please. This is just one point of data for us, and I find this incredible. And this actually was a Commonwealth Care Alliance member, so I could go back in the data pre-cottage living to look at what his ED visits and admissions looked like. As you can see, this is an incredible amount of time spent in the ED between November 1st, 2021 until he came into our cottages in August. He was at the ED or inpatient for at about a cost of, I don't have the exact number in front of me, but over a very short time, a cost of about $170,000. You can see once he was admitted to the cottages, he went to the ED twice. We started him, he was interested in starting on MAT shortly after he started developing relationships. He did continue to want to have services for psychiatric services, and certainly has made a lot of progress. That's not to say that many of our residents, as I mentioned, we are always meeting people where they are at. We have a harm reduction approach to treatment. We understand that people come at various points in their recovery and will leave at various points in their recovery. But we really offer a non-judgmental environment for people to continue their journey of recovery. Thank you, Amy. That's it from me.
All right. Thank you, Lauren. That's amazing. We did have one question pop in that I think would be great for you to go ahead and answer right now. Someone said they're very impressed with the robust list of services you provide, which I also am, and they were curious how you funded that. Could you speak a little bit to the funding around the site?
Yeah, so the funding is directly through the state. So we work directly with the state. We came up with the budget. This was a very new program and an innovative program for the state to engage with us. So as we go through the process and we think about all of the services that we're offering, we're certainly looking at tweaking some of the model slightly. I would love to see the community, a larger community, with the same staffing. So my goal would be to think about continuing with this comprehensive services, but expanding the amount of beds that we would be able to offer.
Awesome. All right. Well, thank you, Lauren. Rest of the panelists, I'll ask you to unmute yourselves and turn on your cameras. And we're going to go ahead and launch into a really nice, nuanced, robust discussion about housing and healthcare. So I'm really excited to introduce you to our panel today. You've already heard from Lauren Easton and know about her and what she's doing. I'm also delighted to introduce you to our next Dr. Aditi brings her vision for a more prosperous, vibrant, and equitable city for all families to life. And not only is she a municipal leader, but she's also a public health researcher, consultant, and educator who's dedicated her career to improving programs, systems, and policies that contribute to community resilience and directly impact children's health and well-being. So welcome, Dr. Bustles. Thank you for joining us. We also have, I'm finally pleased to introduce you to my very good friend, Ethan Shurik, who's joining us today. He is the co-owner of Alluvian Homes and chair of the board of directors of Weld Seattle, which is Pallet's sister nonprofit that equips people that are impacted by the justice system with housing, employment, and resources for recovery. And he is a passionate peer advocate, advisor, and individual with lived experience in addiction recovery. So he's going to be a great impactful voice in our conversation today too. So we're going to launch off with a question to Ethan from his experience. Ethan, could you give us just a quick background of your story and then tell us how the cross-section between housing and substance use recovery, like how that impacted your story?
Sure. Yes. Thank you, Amy, and thank you, everybody here. I love the work that's going on, and it's an honor to be a part of conversations such as this. I am also super grateful to be here as a panelist, but also just to be here, period. I had a background that was it would seem traumatic to some, but I think in terms of addiction and some of the things that we see with people with the homelessness and some of the people that I have tried to help throughout the years, my story is somewhat toned down compared to some of the things that I've seen. But I definitely started using drugs and alcohol young. I had some early trauma happen, you know, in my childhood, and I kind of used drugs and alcohol as a way to escape some of that. And it kind of, I tell people, you know, drugs and alcohol were my solution for quite a while to life, and then eventually that solution started to kill me, you know, and it stopped working for me in that way, and it became the source of a lot of my problems, and it became you know, it took control of my life. And as a result of that, I was, you know, the consequences started to rack up. I got DUIs, I got in trouble with the law. My moral compass just was not around when I was getting high, and it was really just about one thing and my central focus, and that was, you know, when can I get high next, and what do I need to do to get there? And so as a result of that, I got the felony convictions and just really felt dead inside, you know, and the culmination of all that led to me living out of the back of a pickup truck at about 30 years old. I was able to maintain a job as a bartender in a kind of a shady Indian restaurant, you know, and I would sleep in my truck and go to work during the day and go back to my truck at night, and barely held on to that job. That's about as much as I was capable of. And that just that really kind of broke me to the point where I just got suicidal. I didn't want to live anymore. I thought that I just kind of failed at life, and that was, you know, pretty much my darkest moments. Luckily, in terms of the reason why I say my story is not as traumatic as some, is that I consider myself somewhat privileged, and that I'm capable of being higher functioning. I don't have mental illness to go along with my addiction, and I have a family that, while I was separated from them, would answer my phone and be there for me if I needed to, say, detox on their couch for a couple days. So I do consider myself fortunate in that I had some resource to kind of fall back on. And it was somewhat of my own choice not to use that resource or when to use that resource. And I consider myself lucky for that. So what happened was I ended up getting into a treatment center finally. I just got broken enough to the point where I entered treatment. I think it was my third or fourth treatment, to be honest, but I was inside a treatment center, and they were talking about Oxford housing, and that they had some statistic, I don't remember the exact number on it, but they had a much higher percentage of potential for people to stay sober if they lived in the sober housing immediately after leaving treatment. And so I was broken enough on that treatment center that I decided to try to do that upon exiting treatment. I went into a Oxford house, and it was great. That first Oxford house, I lasted in 4 months because I felt so good. I got 6 months of sobriety for the first time in my life, that I thought I was ready to move back out and get back into life. And unfortunately, I was a little premature on that one. And that was actually the run after that Oxford house that started me, that ended up with me living back in the truck. But the main thing is, I did realize that sober housing was effective for me, because I did get that 6 months. It was kind of like incremental steps. I'd never been able to get more than 30 days. And in that housing, I was able to get 6 months. And so when I bottomed out that final time, I knew that was somewhere that I needed to get back to, you know, and I very much remember that feeling when I came back into the Oxford house for the second time, of just safety and knowing that I had a opportunity to be able to rebuild my life in a safe space. And it's hard to describe in words, but just this feeling in my heart, like that was so essential to me, that I was 100% unable, proven to be unable to remain sober on my own, and so having that safe, dignified housing, it was extremely substantial and probably the cornerstone, the main reason, one of the main reasons why I'm here. The approach that I took in order to actually get long-term sobriety was multifaceted. I did do a Suboxone program for 10 days. It was a quick kind of taper thing to get me off of the heroin. I did a quick, like I said, it was 10 days. It was lower dose each day. And then I moved into the Oxford House, and then I did shots of Vivitrol for a year while living in the Oxford House. And then while doing that, I enrolled in AA. I got a sponsor and worked through the 12 steps. And I don't think any part of that would have been possible without that safe housing, kind of first and foremost. And so I think I'll stop with that for now. Try to keep it short. Sorry.
No, you did great. That's amazing, Ethan. Thank you. And one of the
Yep.
things I want to highlight about Ethan, because I know him, is that today he's a business owner, a husband, and a father of a beautiful young girl. So, I mean, it just goes to show you that, change can happen. People do rehabilitate and recover. And so he has an amazing story. But thank you, Ethan, for sharing your story with us. As a reminder, I want to remind everyone who's watching, we do have a Q&A section. If you have questions for any of the panelists or for me, feel free to drop those into the Q&A, and we're monitoring those as we go. Next question I have is for Dr. Bussells. So from your experience as a councilwoman and also as a physician or as a doctor, how do cities and organizations holistically address social determinants of health to uplift these vulnerable populations and contribute to vibrant, healthy communities?
Well, I think I could take the next 30 minutes to answer that question, but I think the most important thing when we're trying to address the root cause of problems that we have in our community, whether it's lack of housing or lack of quality education, or other social determinants like lack of, transportation, you have to really think about scaling the problem in a way that's feasible, and the city can't do it all. And I think oftentimes so many policymakers were afraid to touch complex topics because they didn't know where to start, or they would bite off way more than they can chew. And so coming in my first year, the number one thing we got calls about was homelessness and unfortunately some very negative interactions that folks that were maybe eating outside or walking down our entertainment districts would have with those that were either under the influence or having a mental health crisis. And this was something we got more calls about than, say, water or sewer or customer service issues. And so we knew we had to do something about it. First and foremost, the city needs to really define exactly what the problem is within their scope. And so I always talk about with my partners and our community members that when I'm talking about homelessness, I'm talking about one specific subsection that we are focused on, and we have the right kind of expertise and purview to focus on. We're not going to be able to do what the local United Way does or the local, Homeless No More organization does, but we can certainly do our part to, one, collaborate and convene all these stakeholders, and two, provide that rapid housing that is single occupancy, which we heard over and over again was something that was really missing. So that would be my first recommendation, is make sure that you define the problem in a way that is achievable for the city in order for you to really make a difference. The next thing I would say is there are a lot of experts in the field, and there are also people that don't typically sit in leadership positions in organizations that have some really great insight on the ways in which we can address some of these problems. So we had a task force around homelessness in 2013, which included a lot of the high-level executives from these homeless provider organizations. And unfortunately, none of the recommendations that they recommended were ever implemented, many of which were for their own organizations. So we tried something different, and this was really reaching out to those that work directly with people experiencing homelessness every day. So that's your outreach worker. That's your judge, right, at homeless court. That is your local business owners. That is your public defender. And we were able to get a really interesting perspective. And then once we had an idea of what we wanted to solve, we brought in the organizations and asked them questions about, how do you meet this need or that need? And so I think it's also important to have the right people at the table. It's easy to fall back on kind of the typical players, but that can keep us from really addressing some of the silos. And I think the most important thing that a city can do is really take a look at how the structure of homeless services is functioning and not functioning. So one of the things that we've learned is that our continuum of care, which is the HUD's kind of program around providing funding for homelessness, is 13 counties wide. That's not working for us because we are the only city in amongst those 13 counties that has a low barrier shelter. And so we are taking on a lot more of the burden. And I always say, I want Columbia to be known as a compassionate city, but I don't want my taxpayers to be the only ones that are taking on the burden of some of the issues that come with homelessness. And so that's really where we as policymakers can advocate for a better funding approach or better funding strategy, really, encourage people to stop working in silos and work together and build those accountability mechanisms to help kind of streamline and really truly develop that wraparound services that are very much needed. And then I think the last thing that I would ask all of you all to do that I've learned in my role as the vice chair of our opioid, we have an opioid commission that is basically giving out the funds from the settlement that many states have gotten. And we learned very quickly that one of the fallacies of federal policy is that if you want to go into mental health care, you have to be clean, which makes no sense when you think about how substance misuse and mental illness are often co-occurring. They're not always co-occurring, but often they are. And so when you see that that's an issue in how federal programs have been built, you can see why we don't have a lot of these resources for folks that need, those services that can ultimately lead to hopefully permanent housing and a stable job. And so I ask you all to think about advocating to your federal legislators about changing that. I'm sure it was not intentional, but it has certainly led to some unintended consequences of trying to reach some of the most vulnerable populations that unfortunately, and we can talk more about this in our next question, are resistant to services because of maybe the trauma or the distrust, or maybe just being so deep in their addiction that they're not ready yet to take the help that's being offered to them. So I'll stop there.
Yeah, thank you. That's so great. And I totally agree with you. I think, Pallet very much believes in peer-based services and the benefits and the outcomes that we've seen with those. And so I really appreciate you pointing that out. I think it's so important. And one of the things you mentioned that I think is also really important is the siloing. We see this in a lot of cities and across the US, the siloing of services. And so the next thing I want to really talk about is the importance of cross-sectional partnerships and how we work together and collaborate together in order to create that holistic ecosystem of services that residents really need to find that rehabilitation and get back on their feet and back into life. And so, Lauren, let's start with you. Can you talk a little about the cross-sector partnerships that you've worked with between housing and health groups to combat displacement and specifically close the housing affordability gap, whether it be the Pallet site or other solutions that you've deployed or worked on as well?
Yeah, great. Thank you, Amy. Yeah, I think that building community partnerships has been invaluable in our process. So we start with community-based organizations, individuals. I know Dr. Bustles talked about teams of people that are actually on the streets. So community-based organizations that have street teams that have already identified and started to develop relationships with the individuals that are homeless or marginally housed. I will say specifically at Mass and Cass, working with these individuals for years and years and starting to develop that trusted relationship. I think as both Ethan and Dr. Bussell said, that these individuals' experience are often incredibly traumatic. They have a distrust of the system. They do not want to engage with providers. And these individuals that are community-based organizations that have this experience in this street team work, whether they are peers or recovery coaches or their own lived experience, they're really able to engage and start building that trusted relationship. So I'd say first, those partnerships with community-based organizations are key and significant. Additionally, really working with better access and decreasing barriers to primary care. So what we know when the folks that have come to our cottage community or Pallet community, When they have a safe, secure place to rest their head, get good sleep, start to have good nutrition, we know that their overall medical care is going to improve. They also need that to just start their road to recovery, just a safe place. So we think about partnering with various primary care sites, decreasing those barriers, increasing access. I think also thinking about legal aid. So how do we have medical legal partnerships so that these individuals are able to, as I mentioned earlier, go to the court, get their warrants, addressed. Very important piece of the work that we're doing is partnerships with medical legal aid. I'd say behavioral health as well. Any organization that's offering behavioral health services, psychiatry, to Dr. Bussel's point, programs that are not requiring sobriety, or that you have to take your medication regularly, or you cannot be on anti-anxieties, various things that programs have understood, that these have been policies for them, but breaking down those barriers so that people can come in wherever they are in their recovery. I'd say the last thing that we've partnered with also is cellular phone access, and thinking about some of our partnerships with cellular phone companies. So our residents can have access to cellular phones so that they can make appointments. We can get in touch with them. That's been really key also. So I would say for us, those have been key partnerships. Lastly, one more, sorry, landlords. Landlords are incredible. So having relationships and partnerships with landlords that understand this, this incredible population that, again, has had significant trauma. Yes, they may come in that they're still using, in the throes of addiction, but having these relationships so that the landlords know that we're going to continue to provide services. We're not just having people come, give them the key, and see you later. We want to continue to support them, and we want the landlords to know that these individuals are active in treatment. Yes, they may have some issues, but they're active in treatment and they're wanting to continue their journey of recovery.
Yeah, that's great. That's a great example. And I'm so glad you brought that up, because I think it's a really important part of the equation, in the sense that there's a whole housing market out there, right? And there's the market rate side of things that we're not leveraging to respond to the solution for a variety of reasons. But with landlord liaison programs and innovative solutions, we can access those housing units and help people get placed. Landlords often want to know that those folks are getting services. And so making those connection points are really important. Dr. Bustles, I'm going to jump back to you here. Can you talk a little bit, if you have thoughts around cross-sectional partnerships, would love to hear your thoughts on that too. But then can you also talk a little bit about, from your perspective as a councilwoman, policy shifts and practices that you think cities can leverage to ensure housing and health equity?
Yeah, so in terms of cross-sector partnerships, I think what we saw here was, and this may be something that other cities are experiencing as well, is it wasn't necessarily a funding issue, right? So we had several millions of dollars going into addressing homelessness and its different facets, but people weren't working together. We had a, HUD mandated data system that people weren't using consistently. And, it's easy to get comfortable when you're doing something for a long time. And I really believe that kind of breathing in new life to this task force and getting folks to really think critically about the fact that maybe things aren't working, right? And how can we change some of the things that we're doing? I think one of the big wins that I talk about is, in the beginning, a lot of providers were defensive that the city wanted to get involved in this issue because it was something that they had led on for a long time. And we never positioned ourselves as the experts, but we certainly saw that there was a role that we needed to play, and we had the resources to invest in the issue. And I think over time, as they began to see the very deliberate approach that we took to provide, again, that rapid housing through the Pallet community that we built around our overflow, which is really focused on when the weather goes below 40 degrees and now keeping that open year round. They began to see how, there is a lot of work still to be done, and perhaps there are gaps that they should be addressing. And so I talk about the fact that after the task force finished their last meeting, providers actually came together at the library and had a really, I think, courageous conversation around how things weren't working. And I attribute that to some of the work that we've been doing around homelessness to really bring light to areas that need help. So there's always room for improvement. It's not to attack an organization or tell them they're not doing a good job. I think that everybody's trying their best, but it's okay to also take a step back and recognize when perhaps things need to be done differently. So that's what I'd say about cross-sector collaboration. In terms of policies and practices, I mean, in general, I think there has to be an intentional investment in more affordable housing. So we have funded the Housing First model here at a smaller scale with our university partners at the University of South Carolina. We've actually had 8 people move into permanent housing since last November when the Pallet shelter opened. And, you know, that's not 800, but that's certainly a step in the right direction. But I think it's also helping our constituents understand that when they're asking for affordable housing, and then we get a project that comes across zoning and it's going to be affordable housing, and then these same people come out and say, I don't want that in my backyard, you're really setting up a cyclical nature of not solving the problem. So sometimes it's our own communities that are keeping us from doing the very thing that we know are going to make a difference in terms of housing availability and providing kind of that single occupancy. Another thing we're working on, which is more of a administrative internal policy that we're trying to take a look at, is meal sharing. So we have over, I think, 40 organizations that meal share. Many of them meal share at the same time. Many of them, you know, are doing it on different days. And it was very, I think, uncoordinated. And unfortunately, during COVID as well, with the increase of single-use plastics and using public spaces, we saw an increase of litter. We saw just a lot of things that were not being taken care of in terms of communal spaces. So something that we are trying right now is we are providing a space for those who want to feed using city land. We have designated a space that has bathrooms, that has a commercial kitchen, and it is in the center of the city. And we are trying to see if organizations that are interested in feeding will work together and feed larger groups of people, as opposed to maybe these kind of ad hoc approaches that have traditionally happened in the city. And, you know, that doesn't mean that some of the work that's happening on private property like churches isn't going to continue. This is really more for those smaller groups that have been using maybe traditionally the street or the parks that we have to try and address that. So I think that's something that we are very much looking at in terms of how could that be shaped by policy and practices internally at the city.
Yeah, amazing. So many exciting things. And that collaboration is so important because you get better stewardship of the available resources you have when you work together, right? We have a limited amount of resources that are available for this issue. And it helps when you can collaborate, it helps to spread that resource a little bit further. Okay, one last question for Ethan about his lived experience. And then we have tons of great questions coming in from participants and we're going to jump to those. But Ethan, one last question for you. I know that you've had a lot of experience working in low barrier shelters for folks. You've worked with folks that are in recovery and moving on to housing. You've had a lot of peer-based interaction with folks that have the same experience as you. Can you speak a little bit to that cross-section again of housing and healthcare as it relates to well-being and mental health? I know you mentioned like you don't have those mental health challenges, but you know people who have. Can you talk a little bit about how you see that interaction of housing with mental health and overall well-being?
Yeah, thanks, Amy. Awesome stuff too by the panelists today. I love hearing about all the programs that are going on. It warms my heart. So yeah, I worked for Downtown Emergency Service Center in Seattle as a clinical support specialist in their housing program. So definitely very familiar with Housing First and low barrier housing and see the importance of that. And for me, it was Oxford housing. But like I tried to point out, I have I hate saying higher functioning, but that was the right housing for me, like in my time. And I believe every human should have that, whatever that right housing option is for them, because nobody should have to figure it out while living under a bridge, how they're going to take their medication and get to the doctor and, you know, all the normal survival stuff. So I love the cottage, the pallet philosophy of meeting people where they're at, getting their basic needs met. and I've seen it firsthand from working with Downtown Emergency Service Center, the drastic improvement that occurs within the first few months of moving in and getting a stable, warm, safe, dignified housing. It's essential. For myself, it allowed me, like I said, it gave me that safety, that feeling of just not having to worry about it. I do have an experience. So two things in Oxford House, I was able to do school. I was able to get my medical stuff taken care of. And so I was able to do all that without having to worry about where I was going to rest my head at night, my safety, and that was all perfect. When I moved out of the Oxford House, I had some issues because I had felony charges of getting into even an apartment. When I moved out with my who's now my wife, I had to be put as an occupant on the lease. I was 4 years sober. I was working as a clinical sports specialist with a college degree and couldn't get added to the lease, which made me not feel great at the time. I think some things are going better that way, but that's one of my other kind of passionate areas are people that are formerly incarcerated that have so much trouble just getting into housing based on some of those roadblocks. But yeah, I just think that I don't see much. It's so hard anyway when you're in survival mode, just to get through the day. There's really no time to think about health and what you're going to be doing well without housing. And so I just think there's such a huge need, and the importance is, yeah, it's just extremely important. That's all.
That's so, thank you, Ethan. And I'm so glad you brought up the justice system side of it too. I mean, I think this is something that nationally, we're not having the right conversation. We're talking so much about affordability, which is very important, and we need to continue to develop affordable housing, but we also need to provide accessible housing. And when I say accessible, I mean anyone can live in it, right? And there's 600,000 people a year are releasing from the justice system into the United States cities and counties that you live in. And a vast majority of those folks can't access housing, whether it's affordable or not, because of their felony histories. And, anyway, I won't get on my soapbox about that, but I think it's a really important conversation that we need to continue to have, that, folks who have that background, they then in turn end up facing a number of healthcare challenges after living outside and experiencing the trauma of the prison and jail systems. And there's both mental and physical health consequences of those experiences. So thank you for bringing that up. So we have a number of great questions coming in. I'm going to direct as many of them as I can in this last 12 minutes or so that we have. For any questions we don't get to, don't worry. We're going to draft some written responses. We're going to send those out to everyone along with a recording of this webinar and some follow-up materials as well. So Lauren, quite a few questions for you about the Boston site. So I'll start firing a few of those off. Can you speak to the regulatory requirements around your site, any regulatory barriers that you faced in getting the site set up?
That is a great question. Again, being in a unique position that we were partnering with the Executive Office of Health and Human Services and having a state-owned land that we could build the pallets on was very helpful in terms of the amount of time, or the very limited amount of time that we were able to build. I think that if it had not been on state-owned land, we would have more difficulty getting through some of the fire waivers or other regulatory building permits. I don't have exactly everything that we had to get through, but I do think that decreased our barriers of being on state-funded land. They were able to push things through quicker. Obviously, we were in crisis, but that was helpful. I think the other thing I would just say, and I think to be very transparent, the issue of NIMBY comes up very, very often for as we think about where we want to expand. Many municipalities talk about wanting to build these communities, wanting to support individuals that are homeless and be a part of the solution. However, when we go to present and think about where we build, there's a lot of pushback on, again, not in my backyard, the NIMBY issue. So being on this state property at this hospital that is still operational, Although we did work with neighborhoods for many, many months, and continue to work with the community advisory boards and the neighborhood boards. But, we were able to work through a lot of kind of the concerns around security and safety.
Yeah, that's great. Thank you. And I will add that, from Pallet's perspective, we have, again, done 120 of these sites, and we've worked with cities on creation of other types of innovative housing solutions outside of Pallet's model. Anytime you're embracing innovation, there's going to be some regulatory hiccups and bumps because, people don't know what to do with something that's new and innovative, and that's normal. And often, what we often say is people are afraid of what they don't know. Once they know it, that fear goes away. And so we've seen scenarios like Los Angeles, the city of Los Angeles as an example. The first site we put up lots of pushback and barriers, and we're now on our 15th site, and each site got a little bit easier as constituents and residents of the city said, oh, we've seen this before, we've seen the benefits of it, we're no longer as scared, but certainly we still have NIMBYism. And so Pallet can help with some of those challenges and regulatory barriers in terms of zoning changes, things like that. Another one I think is really interesting, another question here that I'll put both to Lauren and Dr. Bustles for your specific sites. The question is, who has liability at these cottage sites should there be an overdose or injury or death? I think that's a really important question. So Lauren, you want to start?
Yeah, sure. So, we are with our contracting with the state of Massachusetts, so the Executive Office of Health and Human Services, as a nonprofit provider in the state, we certainly do have liability, and we are responsible for and deaths or overdose, and we certainly know with our particular population, this is the highest risk population in Massachusetts, and our organization understood the risk that was going to entail. Again, I will go back to another reason we provide these very comprehensive services for the safety of our milieu, the safety of our guests, our staff. We really wanted a comprehensive model to decrease that risk of liability. But yes, we are responsible for the community in its entirety. The state partners with us, and of course also has liability around offering these services, but ultimately we are responsible.
Okay. Dr. Bustles, you want to answer this one too?
Yeah, so we contract with the Midlands Housing Alliance, which also operates Transitions Day Center and Shelter, which is that low barrier shelter for our continuum of care. So they assist, and then we have 4 staff that we've created an Office of Homeless Services here at the City of Columbia, and they are really the ones that are managing outreach, managing coordination of groups that want to assist our rapid shelter, and then of course keeping the rapid shelter operating. So we have the liability internally because we own rapid shelter. It's on our city land in terms of liability in that sense. And then of course we share some of that liability with our partners that are formal subcontractors to help in administering things like Narcan and other kind of substance use related services. And then we are now expanding to provide some of those mental health and substance use related services with additional partners coming on board this new fiscal year. And so it'll continue to kind of expand in terms of partner liability.
Okay, that's great. That's super helpful. And correct me if I'm wrong, but one thing we hear a lot and we say a lot to city staffers and officials when they ask us this question, because we get this all the time around liability. And we often say, well, technically, aren't you liable for these folks anyway? They're your constituents. They're living on the streets. There's the challenges that they're facing medically and otherwise are the responsibility of the government to many of the constituents, whether it's formal or not. So isn't it better to have them in a managed environment where they're receiving services than an unmanaged environment? Would you agree with that? Is that a true statement?
Yeah, I think that's a good way to put it. We actually haven't gotten this question that much. I think the biggest question has been how can we refer people there? So we have a very formal referral process, but it's easy. It's formal to make it consistent and to be fair with getting folks into the pallet shelters, and allows us to track what partners are doing those referrals, whether it's our hospital or whether it's a citizen that reaches out to get somebody into the pallet program. So that's been typically the question that we get. But absolutely, I mean, we had a person pass away due to hypothermia 2 years ago on the street, and it was because he just didn't know that we had a inclement weather center and shelter that's open. And so that really, I think, set in motion the importance of us showing that we certainly do have a role in protecting some of our most vulnerable communities in the city.
Yeah, that's great. Thank you so much for that. And while you're unmuted, I'll ask you the next question because you touched on this actually. So someone asked about how do you maintain consistency throughout your process of identifying folks that need the help? You mentioned it a little bit. And then in that same vein, the folks that require shelter versus permanent housing assistance, kind of walk us through the intake process and how you assess and make sure it's equitable.
Yeah, so we have an intake process that has been modeled off of a lot of best practices that are what we call our Midlands Area Coalition on Homelessness has already adopted, including using the same data system as all of the providers. So we now have access to that as well. So in an ideal world, you're able to track an individual as they touch different services and be able to kind of comprehensively see where and what was addressed and treated and prevented. And we use a trauma-informed approach using trauma-informed questionnaires to address intake. But again, we keep it very simple so that our providers and our partners and community members can make the referral quickly. And then once they have entered into rapid shelter and have been approved, which is a very quick turnaround for the most part, that's when we start to do more of that intensive social determinants of health assessment. So kind of surprisingly, but not surprisingly, we have an 80% refusal of services currently with this population of about 250 people that are typically engaging in illegal activity on the street. And so it's come to the point of either you're going to take a bed or shelter, or unfortunately, if you're going to be smoking dope on the street, you're going to have to go to jail. And so that's been really difficult. And we're working and trying to figure out ways in which we can build that trust and help people see that we don't have the problem that there aren't beds anymore. The other night we had 28 pallet shelters open. So how can we build, that trust in the community that this is an option and it's a compassionate option. And you're treated like an adult. It's not that we keep you in there. You go in and out, and it is your home for 90 days. And so when it comes to permanent housing, we have case managers on site that we've subcontracted. So they kind of follow our residents as they are staying at the pallet community. And we say 90 days, but that is flexible. If we see someone's doing very well and they have some really great leads in terms of jobs, or they're doing really well in their program, if it relates to mental health or substance use, they can stay longer. But the goal is really then to help them by connecting them to these additional services to then be able to get out into permanent housing. Now, the availability of that permanent housing still is a problem and still is an issue. And that's something I think that holistically the region and the state of South Carolina needs to address. And I'm sure that's the same in other areas as well. But we try to take a very, I think, patient-centered or, individual focused approach to really recognize that there's not one path out of homelessness and that there's going to be a lot of kind of obstacles along the way. But as long as the individuals that are in our community are surrounded by people that care and people that want to help them, perhaps we can start to see more successes come out.
Yeah, that's amazing. Such a good answer. And it is so complex, right? There is no one way to solve this issue for everybody. There's no silver bullet solution, as we like to say. All right. Well, we have so many more amazing questions. I wish we had more time, but we are running out of time. So what we're going to do, I'm going to go ahead and quickly share this last slide again with everyone. Thank you so much for joining us. If you have additional questions, please feel free to reach out to Pallet or scan this code here. In addition, we're going to take all the remaining questions. There's some really good ones about landlord engagement and policies and regulatory reform. And I'm really excited to dig into these with Dr. Bustles and Lauren and Ethan and get the answers in writing for you all. We will email those out to you. We'll put everything in writing so you have it. We'll be sharing the deck and the recording of this as well. So thank you all for joining us today for this very important conversation. And we hope you have a great day and help someone in need in your community. Thanks, everyone.